Hello, my name is Dr. Robert Tawanda Kongora. I work for the Ministry of Health and Childcare in Zimbabwe as the National Electronic Health Record Coordinator. I think it's my pleasure to take you through this introductory discussion where we explore what the National Electronic Health Record is in a Zimbabwean context. Ours being named Impilo, where we explore what that name means to us, what journey we have traveled, and where we want to go, what value we seek, and how we are going to go about it. So you could be the newest or the next Impilo user at your health facility in Zimbabwe and are about to commence training. It is my pleasure to welcome you onto the Impilo journey. It's an exciting journey. We are excited to have you. So I will stop my video and start my PowerPoint presentation. So what is an electronic health record? I'm sure you have heard about an electronic health record being implemented in Zimbabwe. Very recently, it has started gaining prominence in terms of high-level announcements. But if we are to start from the top, in our context, we are not the only country that's trying to implement an electronic health record. And it's very important that we also measure ourselves or locate ourselves against world trends. I quote here Richard Colbridge from Ireland, also equating the implementation of an electronic health record for Ireland as the foundation for the reform of their healthcare system. So he says that a digital fabric is necessary for integrated care and for patients to gain true control of their health. So let's define what an electronic health record is. So it could be called a record of health-related information on an individual. So it has to conform to nationally recognized interoperability standards that can be created, managed, and consulted by authorized clinicians and staff across more than one healthcare organization. Right. So in Zimbabwe, you know, we have Parirenyatwa Hospital. It's a central hospital. It's usually a quaternary, like referral, the highest referral hospital we have in Zimbabwe, which means that a person can be referred from a lower level facility and end up at Parirenyatwa. Essentially, what this definition is saying is that if you were to start at Mtawatawa District Hospital and you were in labor, and your labor is complicated, you would be referred to Marondera Provincial Hospital. And from Marondera Provincial Hospital, you would then find yourself at the Central Hospital because sometimes such complications happen. Previously, we would be writing on a paper partogram because this is labor. But now that you are using an electronic system, what we mean by an electronic health record is if Mtawatawa was using EHR, Marondera Provincial was using EHR, and you end up at Parirenyatwa Central Hospital, these would be able to access your record that was created at the lowest point, providing that all of these facilities have internet connectivity. So that's what we mean. An electronic medical record, on the other hand, it keeps that record within one healthcare facility or organization. That's the difference. In Zimbabwe, we have such an EMR. It's called EPMS. I don't know if you're familiar with it. In other countries, they have personal health records, personal health channels, personal health records. It's a record of health-related information of an individual. And then the other definitions are the same. The only difference is that can be drawn from multiple sources while being managed, shared, and controlled by the individual. A personal health record, I'm moving around with it, and I have to give the practitioner, if let's say I'm moving around with my record, and then I go to consult a medical doctor, then I have to give him the permission to view my record. So that's the difference. So these are also definitions that are trying to split between an EHR, an EMR, and a PHR. Very important when you're going through these slides that you read through them to understand what the difference is. Another definition, so there is what we call the Healthcare Information and Management System Society, HIMSS. They've got the best definition for me in terms of what an electronic health record is. So it's a longitudinal electronic record of patient health information generated by one or more encounters in any care delivery setting. Think of it. So we have been implementing the electronic health record in Tawa since 2016. What we are talking about here is if there were kids that were born and recorded in the electronic health record in 2016, they got their vaccinations and they were recorded in the EHR. They did their growth monitoring, they did their IMNCI visits in the EHR. It means now the EHR is putting together that whole record. Sometimes when we are training in person, we joke and give this vivid example just to make you get the point. What we are saying is essentially an electronic health record can put your entire health record. It doesn't matter where or whether these record or health transactions were recorded at multiple or different health facilities. It means that as long as these health facilities are connected, you can view what was done at all the other facilities in one place, in one record. Be it demographics, medical history, vital signs that were recorded. The last time you went to pick up your drugs at Parenyatwa, but now you're back at your usual district hospital. So they can see what happened at Parenyatwa. If you're going to move to avoid your usual health worker whom you know from your local clinic because maybe you go to the BRO together, if you're going to try and avoid them because now you have an STI and you don't want them to know, you go to another health facility. What we are saying, just to use this vivid example to bring about the point, is the moment you come back to your usual health facility, there is potential that that health worker can access what was done at that new facility that you visited to have your STI treated. So that's what we mean. Right. These things that we are doing, we do not claim to have exceptional genius. These are things that other people are also trying to do. So when we look around, we put together studies and try and find out what others are thinking, what others are finding in the implementation of EHRs. So you need national standards and coding systems, you need funding, you need your physicians to use it, and then you need skilled human resources, local data networks. You find that the way we are implementing our electronic health record is actually we are studying what the others are doing and trying to factor it into our own implementation. Stone in 2014 says, many EHI implementations have failed due to lack of involvement and leadership. So you find that it's very prominent in the next two slides that we have very decisive and transformative leaders. strong governance structures. So you find that the way we are trying to do it in Zimbabwe is to have is central to our implementation, top government ownership of this program, right? And also leadership and governance structures that are firm and transformative, because we didn't just come up with it, hit and hand in 2013, observe the same, right? So, and then the others, Boonstra, Veslui in 2014, also say that due to their influential position, management's active involvement and support is positively associated with EHR implementation success. So we like that. We also want for there to be participation of clinical staff, and that these clinical staff, who are the end users of the EHR, be fully trained. And then after being fully trained, they are provided with real-time support. That's very important. And then a comprehensive implementation strategy by an interdisciplinary group of people. Your implementation group must be interdisciplinary. So we have heard that you need clinicians, but we also then realize that you need members of the IT department and end users. You need the end users in those implementation groups, right? So clinical staff are very important, right? Especially when you can identify champions among those clinical staff, because that's going to reduce resistance, right? As you implement, we focus on the technology. So sometimes it becomes, people forget that beyond the technology, there are also organizational aspects of EHR implementation, where we talk about ownership, governance, and implementation fidelity. And then we mean by implementation fidelity, we're just talking about you have a plan, and then you are adhering to that plan. You are adhering to your roadmaps, to your plans, to your strategies and your goals. And then there are financial factors. So approach is informed by McGowan and company. So very important. Why did we suddenly start implementing in EHR, beside what Core Bridges is saying, that it's foundational to any health sector reform? There are also other advantages, and we may explore a few of them, right? Paper-based systems are less intelligent. They provide less clinical decision support. So if I'm going to enter a temperature of 40 on paper, I could just enter a temperature of 40 and go home and sleep. The paper would not talk back at me. It would not remind me that there's something wrong with that temperature. So, but if you have an intelligent system, an electronic system, the moment you enter the temperature of 40, it's going to do some validation and tell you that according to the range of normal temperatures that I have, this is an abnormal temperature. Are you sure this is a normal reading? And then you say, I'm very sure. And then, depending on the level of clinical decision supporting that system, it can start suggesting things to you like test for malaria, for example. Can you do A, B, C, D? We have a high temperature here, and you were supposed to do A, B, C, D at the very minimum, and you did not do it, and you're about to send this patient home. That's clinical decision support, something you don't find on paper. Paper-based records are poor at moving a record from one point of service to another. During one training, I was busy asking people that when patients, you hear stories about people putting efavirenz in chicken feed or in nyaope, and we're busy wondering, like, where are they getting this efavirenz? Are they buying it from pharmacies? Are they moving around between our facilities and then pretending like they're new? Or I add patients so that they can just be tested afresh and be started on ART afresh so that they can get ARVs? Is it possible? Or maybe it's possible. Or do we sometimes think that some of our patients are lost to follow up when all they've done is move from one point to another to access care They've moved for socio-economic factors. They didn't tell their last facility. And then the last facility just thinks that they are lost to follow-up, when in fact they are accessing care at the next facility. So electronic systems, if there is internet connectivity, are better at tracking patients across facilities, especially the EHR. Paper, use of paper, it brings with it general redundancy. When we say general redundancy, we are talking about, and then duplication of data entry. We are talking about the fact that if a woman were to come to you with vomiting and she's of reproductive age, sometimes, or not sometimes, one of the things you are going to think about is could she be pregnant? So if she's pregnant, we're going to test for pregnancy. If you find that she is actually, she tests positive for pregnancy, the other thing that you are going to need to do is an HIV test. Or God forbid that she tests positive for HIV. So now you're supposed to do, to fill in the OIR booklet. So if you trace that whole process, you find that when she arrived, you filled in an attendance register. She probably had her own booklet, which she brought to the facility, which you started writing in, the temperatures, the vitals. When you did your consultation, general consult, now she turns out to be pregnant. That's an antenatal care register. And then the maternity booklet, because now she tested positive, HTS register because she tested for HIV, and OIR booklet because she tested positive for HIV. In all of those books or paper tools, you are writing the name, the address, the gender, and all of this is the same information. Electronic systems like the EHR, what they do is they automate the process of reporting and record keeping, because then you only enter the name once. Whatever service you don't provide afterwards, the system knows what the name is, and then that's an advantage. Paper records, storage. So especially at the hospitals, we know we have a records room which is usually full of old papers. And I think they were supposed to be submitted, if I'm not wrong, the National Archives. And I think the National Archives is now full. Where are we going to send all of that paper? Do you think what was written on those papers is still legible? Or do you think if our colleagues, the medical doctors, were writing on those papers, do you think you can still read what they wrote 20 years ago? No, but electronic data, when it's stored, it requires less space, it's easier to read. So those are some of the advantages. The other advantages: accurate, up-to-date, and complete information, quick access to patient records. You can securely share electronic information with patients and other clinicians. That's an EHR now. Helping provide and effectively diagnose patients, elements of clinical decision support, improving patient and provider interaction, safer and more reliable prescribing. So you can go through this whole list and see what the advantages are. There are many of them. And when you start using the EHR, you start experiencing it. Right. So the Impilo electronic health record. Impilo, life, good life in our local language of Isindebele. And then health if in Zulu, right? And then this is a name we gave to our electronic health record. Why? Because it was developed 100% by a Zimbabwean technical team. When you give birth to something, you give it a name. It is proper. And in the Zimbabwean and Ministry of Health and Childcare context, Impilo describes an ecosystem of interoperable or integrated solutions or applications that communicate through what we call a health information exchange. So, Impilo, as far as you are concerned, if you are at the point of care, maybe one web application, but Impilo also means there are other plug-in applications or related applications that are within its ecosystem, right? So within that framework is a point of care solution called the Impilo electronic health record. We started in February 2016 with support of many partners, PEPFAR, CDC, the Global Fund, UNFPA, UNICEF, CODE. So we have received it. Not only that, we are now working, as I will mention, with local institutions. The Impilo EHR solution is licensed under the Ministry of Health and Childcare in Zimbabwe. It's also a freely available software, which means anyone who may want to access it, for now they will have to talk to us because it's on public GitHub repositories. So GitHub being a repository, like an international accessible repository of software, it is there, but we just haven't published it or made it into public repositories where everyone can access it, right? When I was saying health information exchange, this is what it looks like. So when we say Impilo, there's the Impilo, a philosophy, our philosophy and approach to integration, that we think that it is impossible to reasonably implement an EHR and expect longitudinal tracking across facilities and across systems without implementing a health information exchange. So when you're at point of care, you think this is the only, Impilo is this only, but not necessarily. When we say Impilo, we're also referring to our entire exchange. You have a point of care solution called Impilo. You have a mobile app also called Impilo. And you also have other systems that are plug-in called Impilo, right? So, trying to move from paper, trying to avoid going through multiple electronic systems, but going directly to an integrated electronic system. That's the goal, right? The project was commissioned by the Ministry of Health and Childcare. And like I said, we hold the intellectual property. The Impilo is open source technology, and also we develop it in a user-centric manner, which means that health workers like you and me are at the forefront of informing how software developers must customize the solution for our needs. It took into account our reporting requirements and will contribute towards the automation of the reporting process, thus relieving point of care health workers of a key burden, which is to report. Of the solutions currently in use, EHR is the most comprehensive and widest in terms of patient care functionalities. We have already begun efforts of creating wide local capacity for its development, deployment or support, maintenance, and sustainability. We adhere to what are called the 13 principles of digital development: build with the user, build for sustainability is one of the two of the 13 principles. Right. The origins, I sometimes joke with people and say, all good things in Zimbabwe start in UMP district. It is true. That's where the Impilo started. This was the first district to implement the Impilo, February 2016. That's when they started. Now we are in 2021, and we hope to keep going. Right. There was involvement of health workers, primarily informing at the beginning an agile software development team, which was under RTI Zimbabwe, and now ICAP. All of these were supported by a grant from PEPFAR through CDC. But then, as we have matured, we've also started having collaboration with the Global Fund, CODE, UNFPA, Gavi, also Bill and Melinda Gates Foundation, and then more importantly, involving the local institutions of knowledge, the University of Zimbabwe, Chino University of Technology, Harare Institute of Technology, and then other collaborations are starting to form the University College of London, and then Baobab Seco, right? Achievements to date, the licensing I've mentioned. The other thing we must mention, as I have said from the beginning, leadership and ownership is very important, especially if you can have it at the highest level. The MHCC has placed the implementation of Impilo on its high 100-day priority project list, right? So the current government in Zimbabwe runs on cycles of 100 days where they prioritize projects. The Ministry of Health currently in its current cycle, which is ending on the 24th of July, has the Impilo, there's a rollout of the Impilo as one of its top priorities. We received direct budgetary support from central government, the first time that happened, beyond the usual support in terms of human resources. When they started funding the procurement of hardware and equipment was in 2020, but that has since increased to 4.5 million in 2021, and this is in US dollar equivalent, right? What this means is it makes the government of Zimbabwe one of the top funders, the biggest funders for the Impilo EHR. I mentioned that we are starting to collaborate with a growing community of practice, and also we started very few modules. Now we have 18 of them. I will talk about modules later on. And the Impilo now is talking to other systems, which is called interoperability. When you can see data which was generated in the Impilo, now showing up in DHIS, and that is automatic, that's called interoperability. You have your reports on data which was generated in EHR, now showing up in DHIS, interoperability. You can have lab testing data, like a test result, which is submitted to a lab, and they use a system called Laboratory Information Management System. Results coming back to Impilo, again, that's interoperability, right? Collaboration with the Ministry of ICT, that's one of the achievements. Mobile app development, one of the achievements, and also paper reduction, right? Impilo is a solution or a product. Let's describe a bit, right? So I spoke about modules. In our context, when we're talking about modules, we mean basically the packaging of certain functionalities or the packaging of certain process flows or clinical decision support. For example, if you say a tuberculosis module, we mean that this is how we have standardized the provision of tuberculosis care services in the Impilo. So we know the EHR is trying to enforce a certain standard of care for a patient who might be a suspect for TB or who actually has TB. So when a module is being deemed to be in production, it means it's already being used at sites, right? And the module which is planned in terms of development. It will be developed and added. This we do as we continue to mature our electronic health record. We want to add additional functionalities that we think may make our own Impilo solution more complete. So that's the health investigations module, making the current investigations in the EHR clever and more intuitive. Health service costing and billing, we refer to it like that because sometimes a service is provided and a patient does not pay fee for service, which means that someone else is paying for it, but that service did not come at zero cost. We just want to know for all of our services, for each and every service provided, How much did it cost? So that's why we put costing first. And then if there is a fee for service for such a health service, you can generate a bill and give it to the patient, right? Picture archiving and communication. Take your VAC image, compress it and upload it onto the patient file, or take your X-ray image and then upload it. That's what we are talking about. Right. I have already talked about modules, how we are building the Impilo with modularity and extensibility in mind. Modules in the Impilo are components of clinical decision support, which is essentially incorporate standard healthcare protocols, guidelines, algorithms, and logics. Basically, we have an algorithm for testing for HIV, right? There's a way in which we test for HIV, right? So there are decisions that we go through. Screen first. Have you ever been tested for HIV? Yes. When were you tested? No, 1 year ago. So you're eligible. And then you get tested. And then the next thing is you are selecting which testing kit is going to be used first. If it's positive, system then says proceed to use this second kit for confirmation. And if it's positive again, then the system says this is a true positive. So when the EHR incorporates that, we call of that a module. Initial functionality was biased towards primary care, but now we are incorporating more and more intelligence into the system, right? We have adopted the health information management society, it's electronic medical record adoption model, EMRAN, to constantly evaluate ourselves and see how well we are doing in terms of our own implementation. We regularly release newer and newer software releases, updates, versions, and we anticipate that in the short term, we are going to add newer modules, and then we will have a version 1.3. So basically, I showed you a list of modules that we intend to add, and then these are the versions through which we will do it. Version 1.2.6, we will add more intelligence in clinical examinations. We'll also add more functionality for inpatients and add more in terms of HIV services, especially prevention, pre-exposure prophylaxis, post-exposure prophylaxis, voluntary medical male circumcision, is modular additions to the EHR, where we are adding process flows that make the provision of post-exposure prophylaxis more structured and more intelligent. Cervical cancer screening now is there, but we're adding slightly more features in terms of treatment services that follow after someone has been screened and been found to be positive, right? So version 1.3 coming before the end of 2021, we'll have a new health services costing and billing module and a new picture archiving and communication service in the expanded cancer services. So we just talked about cervical cancer in version 1.2.6, but now we want to move to a broader cancer services, right? We talk about version 1.2.6. At what point did it become 1.3? Whenever, in terms of our nomenclature, if we introduce a functionality, a feature that's going to literally affect every part of the system, like this health services costing and billing module, most of the things Most of the services that are provided have an attendant cost. So we believe that the health service costing and billing module will be wide-ranging in its effects in the system. So deserving of moving from 1.2 and its series of versions to now 1.3. How is the Impilo developed? Agile software development, right? I put the definition here. You can go and read more on those links that are on the slide, but sometimes it's written agile. It's a practice involving discovering requirements and developing solutions through collaborative effort. Self-organizing, cross-functional, and their customers. Is self-organizing and cross-functional teams and their customers. We did speak about how we are doing or adopting or using the user-centric development methodology. We locate the user at the forefront of the implementation, of informing requirements, or informing the design of the system, of informing the outputs of the system. So Agile advocates for planning, adaptive planning, evolutionary development, early delivery, and continual improvement. And it encourages flexible responses to change. Why is that important? The health sector is dynamic. The alternative to agile software development is called waterfall software development. Essentially, you sit around with your software programmers, you teach them about healthcare, how is healthcare provided, it's going to take them. I know in med school it took me 5 years. I don't know how it's going to take. How long it's going to take to educate software programmers. When you're done, they come and then they after 5-6 years having developed a near perfect solution, and the moment they reach you, you are no longer talking about this method of care or this treatment regimen. You have shifted. You're no longer talking about Stalanev for ART. Now we are talking about Tenolam-D. So the health environment is very dynamic, and it would take an approach that uses early delivery. So deliver something, perfect it as you go, make it better, add more features, add more functionality as you go. Agile, that's what we use. So I said user-centric. I mentioned that we have an antenatal care module. How was it developed? How was the delivery module developed? What it means is that there were actually sessions where health workers, primary care nurses, RGNs, midwives, obstetricians, program people at our ministry head office, sat across software developers and taught them how a baby is developed, is delivered. What is dilatation? What is descent? And then software programmers took those requirements, translated them into software, came back and met the same health workers and said, do you accept what it did? That's a user acceptance meeting. Users then say, nah, you need to fix this part. This is not what we meant. Back and forth, until these users were happy. Then they said, okay, let's go and test it at a particular health facility with actual patients. That's called field testing. And then you do another back and forth. And then if it passes there, it goes everywhere else. You continue to use it and optimize and customize as you go. That's agile. That's the diagram. That's trying to show you that we don't wait for too long before we develop another feature or optimize an existing feature. And then 2 to 4 weeks, we ship out. Shipping out means we are sending it to users at sites for them to start using an updated feature of the EHR, right? That's Agile again. These are the team members in the Agile team, right? Design principles that we are using. We want it to be user-friendly. We want it to be usable across all levels of care. It must find relevance at the primary care facility. It must also find relevance at the central level, because sometimes patients may move across those levels. A reduction in duplication of information captured. We are going after that redundancy, right? We want to be able to track our patients. We want to enhance decision support and then be able to monitor patients in real time. We want it to be as interactive as possible, as usable as possible, as useful as possible. That's the same design approach. We are not trying to build a solution that speaks or that talks back at you at the beginning. We want to build basic functioning. And then after building in basic function, we want to build basic outputs, reports, the everyday workplace reports. And then we will incorporate more comprehensive logic as we go. You find that even in the system, some modules are more advanced than others. And we want to build in capacity to respond to more ad hoc requests. So I've mentioned that it is a priority and that currently it sits under the Preventive Services Division. We get support from the Curative Policy Planning M&E Division. We have a new Health Informatics and Data Analytics Directorate, which is where the Impilo EHR implementation is housed. And we harmonize our efforts with our ICT colleagues, health information colleagues, programs, and M&E. I did say at the beginning that the governance of an EHR, when you are implementing it, you need to make sure that the governance is sorted. That's why we are going through these slides. Very important. There is an integrated EHR task force and a community of practice, right? Which bring in other government departments, wider stakeholder contributors. So this is what the task force looks like, right? Chaired by the Secretary for Health, with other divisions. Health Informatics Directorate is really like the Secretariat performing the function on behalf of the Secretary for Health. These are the other members. Others have already become active. Others are being co-opted as we go. But these are the other members in terms of funding partners, technical partners, donor partners, universities and polytechnics. We envisage incorporating nursing schools. We're already working with POTRAs, and the Ministry of Finance, like I said, they've already given us $4.5 million US this year. Ministry of ICT, like I said, we've already started working with them. A community of practice for EHR is a sustainability model, right? Imagine that there are ICT graduates that are sitting around at home. Can they contribute? Can Harare Institute of Technology contribute? Start to understand how the Impilo is wired, how their students, how their academics can study what the EHR is about, how to inform better implementation. Yes. So how do you harness all of that? You build a community of practice, community of contributors. They don't need to actually just be in Zimbabwe. They can be everywhere. People that just love the idea of contributing to something that is a global good. Right, governance, we stay at it. The Impilo EHR is a point of care solution. Its implementation must be as local as possible. I am a clinician, I'm trying to attend to a patient. It doesn't make sense for me to be supported by someone who's sitting at head office. We need to decentralize. We are decentralizing and capacitating sub-national structures to run the implementation, to ensure that there is an efficient and effective decentralization. There must be well-coordinated leadership and governance systems across all levels, right? At provincial and district level, where the systems or the teams are interdisciplinary. Management, technical staff, implementing partners, working in outlying geographical areas. Led by the provincial health directors, it used to be called provincial medical directors, right? So we're not going to set up an Impilo EHR focal person or coordinator at the provincial level. No, that only creates parallel structures. We believe that we should strengthen the existing structures. The Impilo is cross-cutting. It's going to affect all of or most of the operations at point of care. So we don't need to create parallel structures. The people are already there. So PEDCO, the PIMCHO, the PNO, provincial pharmacies, PHSA, very important. A lot of hardware, a lot of ICT equipment is being moved to facilities. It needs maintenance, it needs to be kept securely. So very important. The PICTO, this is technology, most of it reliant on ICTs and digital platforms, very important. That the PHIO, who becomes part of the core team because of how the system is handling and generating a lot of data. Monitoring and evaluation becomes very easy when information is available. The PMD may incorporate others as he sees fit, but he must also incorporate implementing partners working at provincial level, and they should be represented in the team. Right. What are the roles? Leadership and governance. They translate the policy as enunciated by the Secretary for Health, the top management team. They lead in the deployment of infrastructure, ensure that it's documented, supervising the continuous maintenance and testing of Impilo infrastructure, initial and ongoing capacity building for health workers through trainings and mentorship activities, higher availability of Impilo for site level users. Higher availability, we mean whenever I need to use it to attend to my client, it should be available for me. Support and supervision activities, regular data quality assessment, resource mobilization for the Impilo. Again, at district level, there must be a team that is consciously trying to implement the Impilo, led by the district medical officer with support of his district health executive. The members reflect or mirror what we propose for the provincial level. The DHSA also very important. The pharmacist also very important. One of the key features of the Impilo is its ability to account for commodities at the last mile. So let it be used. Let the district pharmacist be a key member of the Impilo. Right. If there is a hospital in that district, the medical superintendent and the hospital matrons must be part of the DIT. Meaning that if you have 3 hospitals, the med sup and the hospital matrons must be part. And the lab scientists, DHIO, very important. Lab scientists, because one of the features, functionalities of the Impilo is its ability to collect a sample and submit it to the lab, right? And also receive a result from the lab information management system. A result we need for patient care. So, very important that the lab team be conscious and be able to use the EHR. For sites that are small, that's the only thing that will be there, right? So you do your tests and you record them on the EHR. Community health nurses, very important. Also to incorporate the sister in charge, representative of the sisters in charge in that team. This is the team that is going to decide, manage, plan the district implementation and supervise the ongoing implementation, post-initial or post-deployment training. So the roles more or less the same. You want to implement, you want to deploy and document, you want continuous maintenance of the infrastructure, capacity building, training, mentorship, and also ensuring that the EHR is always available, up and running for health workers to use, right? Support and supervision activities, resource mobilizations. So when you mobilize resources, hardware, infrastructure, hardware replacement and maintenance, some of these costs may be met at sub-national level, or some of the costs will already be provided for at the national level, where the national level just channels the resources to the respective districts or provinces. Human resources, capacity development resources, communication, logistical support. So when you are thinking what resources may be required to implement an EHR in your location or your area, these are some of the things that you need to think about. What are the plans? We are scaling up, rolling out, as announced by the Minister of Health or the Minister of Information and Publicity in Zimbabwe. It is central government's role. It is central government's plan to roll out the Impilo, electronic health record, to all health facilities in Zimbabwe, to link it with current systems, to develop additional modules, to buy equipment, and also to train health workers to be able to use the Impilo. Right. EPMS, EHR. So I mentioned when I was defining systems that we have a system that we have been using for HIV care. This system has been integrated with the EHR. We will move all the data that was in the EPMS into the EHR. The EHR, the Impilo, now has all functionalities that were in the EPMS and more in terms of HIV care. So there's no more need to have these two systems running at the same site, side by side, because the EHR is now essentially your EPMS plus more. So a site that has been using the EPMS must ensure that they update their EPMS before they go live in the EHR. There will be technical teams that take the data that was in EPMS, do a process called data migration, which moves the EPMS data into EHR. Suddenly, all your 10,000 clients that you had and all of their visits are now accessible in the EHR. And then after that, the site then transitions to using EHR. The data entry clerk who was at that site supporting retrospective data entry now shifts to become an EHR support officer. This is stated in our SOP's document. We have a toolkit that we have shared with you. Please go through the data migration SOP, and then you will find detailed information on how this process is to be conducted. Right. We are moving fast in terms of our rollout. We are paying attention to the technology, the organization, the governance and leadership around it. We want to expedite it to reach as many facilities as possible and to saturate entire districts, as opposed to just doing a few facilities within a district. Right. Usually, there's a baseline survey before EHR is rolled out to a facility. This is going to inform what hardware is required, the baseline indicators in terms of that facility, how long it takes to consult a woman who's come for antenatal care, for a general consult, because we will use this data to regularly measure how well we are doing after adopting digital platforms like the Impilo EHR. Then you have trained. Training can be an in-class training, but recently we are moving towards blended learning, where you are giving electronic and paper materials and very little on-site support, and then you are going to go through the learning materials with or without support, which is physical, and then after the training, you are given support, mentorship, ongoing mentorship, support and supervision. Right. How do we deploy the EHR? We distribute it. We don't centralize the EHR, as in we do not put the EHR software on one central server, which is going to service our 1,900 facilities. Why? Our internet connectivity is very unreliable in Zimbabwe, especially in the rural areas, which means that if we had centralized the implementation of the EHR, we would then require every facility to be connected to that central server or repository via the internet. So we didn't do that. So we put a server at every facility, accompanying that server. That server will be operating within a local area network, which means that you do not require internet connectivity to be able to access the EHR. You don't. Only for facilities, for data to be shared between two different facilities, do you require internet. When you are within a facility, you are using a local area network. It does not require internet for you to attend to your client, which means this is the local area network that's going to facilitate for your FCH and your maternity ward to be able to share the data on the patient that was first attended to in FCH and then admitted to the ward. So the local area network facilitates for you to see what those guys in FCH do. You're given a tablet computer. It's portable, it's light, it's got lighter power requirements, it's a cleanable, small interface. That's why we like it. But that's not to say you can't use a laptop or a desktop to access the EHR. As long as they can get into the local area network, you can use them. All of this equipment requires power. So we are on the grid, you use ZESA. But when ZESA goes down, you have power backup so that we continue to work. Also, that facilities that are not on the grid are then given solar power. Some key messages. Now that we are talking about automation of reports, even between systems like EHR and DHIS, do we no longer require health information officers? No. In fact, health information officers are going to enjoy their lives because information will be readily available for them to package, for them to inform care, for them to share. You should be seeing how difficult it is to compile statistics for daily COVID-19 vaccinations. So now when all of this is automated, it makes it easier. Your jobs are easier. And then when the health information job is easier and they can package information better for the M&D officer, it means the M&D officer is enjoying their life because now they can measure things and evaluate things much better, right? The same for data entry clerks who have already mentioned that they are going to transition to EHR support officers. Another point to emphasize is this. Usually we use this example. We keep a lot of health information. A lot of it is sensitive. All right. What it means is if someone comes to you and says they did not go to the usual health facility because they have an STI, they don't want to be known, which is they are within their right to want to seek privacy and confidentiality. An electronic health record means, like I said, it's possible that when they go to the next facility, that record can be accessed by the person with the right credentials and the right level of access, which is permitted by our own regulations and by our own laws and by the rules of our own health practice. When we were entering names of people who, for example, tested positive for one disease or another, or we were keeping that information on flat paper registers that were physically located in a specific room. But because of the fact that this data is now digital, it means it can be accessed but not so well-meaning people, it can be potentially accessed. That's why we put physical security. The server is under lock and key, should be under lock and key. To access the system, the tablet that you're going to use must have a password. The local area network has a password. For you to access the system, you need an IP address to do not display it on walls. Do not display password on walls. Do not say or save your password or your user account credentials on the browser, right? And then when we send information around facilities, it is over a virtual private network. This is some of the documentation you may need. It is also well documented in the toolkit. So I'm sure if you are going to go through the toolkit, you'll find this information. Thank you very much. Enjoy the rest of your Impilo experience.